All right, everyone, welcome back. Today, we're going to tackle something really fascinating, fetal blood. We'll get into how it's made, what makes it so different from our own, and critically, what happens when things go wrong, when a mother's and baby's blood just don't get along. This is a huge topic in clinical medicine, so let's jump right in.
So, here's our game plan. We'll start with how fetal blood gets made, then the special hemoglobin it uses. After that, a quick refresher on blood groups, which leads us right into the main event, hemolytic disease of the newborn. And of course, we'll finish up with how we prevent and manage it. Let's get to it.
Okay, let's start at the very beginning. Where do these fetal red blood cells actually come from? The process, as you know, is called erythropoiesis. But what's really cool about the fetus is that the factory for making these cells, well, it doesn't stay in one spot. It actually migrates as the fetus grows. So simply put, fetal erythropoiesis is just the process of making red blood cells or erythrocytes in the fetus. But the key thing to remember is that it happens in a specific sequence at different anatomical sites. Think of it like a traveling roadshow, where the main stage moves from one organ to another as the fetus matures. It all kicks off in the yolk sac, really early on, from about week 3 to 8. Then, around week 6, the liver steps up and becomes the main production center. For a bit, from weeks 10 to 28, the spleen helps out too. But then, starting around week 18, the bone marrow starts to ramp up, and eventually it takes over completely, and that's where it stays for the rest of our adult lives. And of course, there's a classic mnemonic to help you remember this sequence. Just think, young liver synthesizes blood. Yolk sac, liver, spleen, bone marrow. Super simple, and it sticks in your head. Okay, so we've got the factory locations down. But what about the product itself? Specifically, what's inside those red blood cells doing the actual work of carrying oxygen? We're talking about hemoglobin, of course. And it turns out the fetus has its own special high-performance version. So that leads to a really important question, right? Why? Why would a fetus need a special kind of hemoglobin? Well, it all comes down to the environment. The womb is a pretty low oxygen place, and the fetus has a huge challenge. It's got to pull oxygen away from its mother's blood across the placenta. And this is where we get to the good stuff, fetal hemoglobin, or HbF. Its job is to transport oxygen, but its structure is different. Instead of the 2 alpha and 2 beta chains we see in adult hemoglobin, HbF has 2 alpha and 2 gamma chains. And that little switch from gamma to beta, well, it changes everything. So let's compare them side by side. The big functional difference is that fetal hemoglobin HbF has a much higher affinity for oxygen. Think of it like an oxygen magnet. And why is it so greedy for oxygen? It's because it binds less tightly to a molecule called 2,3-BPG. Now, 2,3-BPG is what tells adult hemoglobin to release its oxygen. HbF kind of ignores that signal, so it holds on tighter. This allows it to literally rip oxygen away from the mother's hemoglobin as their blood flows past each other in the placenta. It's an absolutely brilliant system. This table really lays out the whole story of this globin chain switch. You can see that early on, in the embryonic stage, we have these zeta and epsilon chains. Then they get swapped out for alpha and gamma chains to make our star player, HbF. But the real switch happens around birth. Gamma chain production plummets and beta chain production takes off. That's how we end up with mostly adult hemoglobin, HbA. This switch is so important clinically, especially when you think about diseases like thalassemia. If you need a quick way to remember this, just think, alpha always, gamma goes, becomes beta. It's that simple. The alpha chain is the constant partner. It's the other one that switches out, gamma for the fetus, beta for the adult. Okay, we've got the cell and its contents down. Now let's talk about the identification markers on the outside of that cell. We're going to focus on the 2 big ones you absolutely have to know, the ABO and Rh systems. So the ABO system, this should be pretty familiar to all of you. It's all about which antigens, A or B, are on your red cells and which antibodies you have in your plasma. But here's the bit I really want you to lock in. Type O individuals have both anti-A and anti-B antibodies. And critically, some of these are IgG, which, as we know, is the only antibody class that can cross the placenta. Keep that in mind, it's going to be important later. Next up is the Rh system. This one's a bit simpler. It really boils down to one antigen, the D antigen. If you've got it, you're Rh positive. If you don't, you're Rh negative. The crucial part here is that an Rh negative person does not have anti-D antibodies floating around, unless they've been exposed to Rh positive blood.
Once that exposure happens, they make anti-D antibodies, and you guessed it, they're IgG. They can cross the placenta. And this brings us to the clinical heart of the matter. This is where all that basic science, the cell types, the hemoglobin, the antigens, all comes crashing together. We're talking about hemolytic disease of the fetus and newborn, or HDN. Let's just break down the name, right? Hemolytic, blood destruction. That's exactly what's happening. It's a condition where the mother's antibodies, those little IgG soldiers we talked about, cross the placenta and literally start destroying the fetus's red blood cells. It's also called erythroplastosis fetalis, which sounds complicated but just means the fetus is trying to pump out tons of immature red cells, erythroblasts, to compensate for all the destruction. But wait, how does this even start? How does a mother's immune system get sensitized to her own fetus's blood in the first place? Let's walk through the mechanism, focusing on the most classic and dangerous form, which is Rh disease. Okay, so picture this. Step 1, we have an Rh-negative mother, and she's pregnant with her first Rh-positive baby. During the pregnancy, everything is usually fine, but during delivery, there can be a bit of fetal-maternal blood mixing. The mother's immune system now sees these foreign Rh-positive cells for the first time. So step 2, her body mounts an immune response and produces anti-D IgG antibodies. Now she is sensitized. That first baby is born and is totally fine, but the problem is now she has these memory cells and these IgG antibodies. So in her next pregnancy with another Rh-positive fetus, those maternal IgG antibodies can cross the placenta from day 1 and attack the baby's red blood cells, causing hemolysis. Now let's contrast that with Rh disease. While Rh disease is severe, ABO disease is actually way more common, but thankfully it's usually much milder. The key difference you have to remember is that Rh disease affects subsequent pregnancies, but ABO disease, it can happen in the very first pregnancy. Why? Because as we said, type O mothers already have anti-A and anti-B IgG antibodies naturally. No sensitization event is needed. It usually just presents as some mild jaundice after birth. So now that we understand this really dangerous mechanism, the obvious question is, what can we do about it? How do we stop it? Well, the good news is this is one of the absolute triumphs of modern obstetrics. We have an incredibly effective way to prevent this from ever happening. The whole principle of prevention is really quite elegant. We just have to stop the mother from making her own anti-D IgG antibodies. That's it. If we can prevent that initial sensitization step, the whole cascade never gets started. So how do we do it? Well, prevention is key. We give Rh-negative mothers an injection of something called anti-D IgG, commercially known as RhoGAM. We give it around the 3rd trimester and again after delivery. What does it do? It basically finds any fetal red blood cells that have leaked into the mother's circulation and mops them up before her own immune system has a chance to notice them and react. It's a form of passive immunization. Now, if the disease does occur, for mild cases we can use phototherapy to break down bilirubin and treat the jaundice. For severe cases, we might have to do an exchange transfusion to get rid of the maternal antibodies and the high bilirubin levels. All right, let's wrap this up with a super quick summary of the key takeaways. 1. Fetal erythropoiesis. Remember that the sites shift from the yolk sac to the liver and spleen and finally settle in the bone marrow. 2. Fetal hemoglobin, or HbF, has a high oxygen affinity because it doesn't bind 2,3-BPG well, which is absolutely essential for getting oxygen in the womb. 3. Rh incompatibility involves an Rh-negative mom and an Rh-positive baby, leading to sensitization and potential for severe disease in later pregnancies. And finally, 4. ABO incompatibility, usually a type O mom and a type A or B baby, is milder and can affect the firstborn. And that really covers the essentials. It's just amazing when you think about the delicate immunological balance that has to happen during pregnancy. And here's something to think about as we finish up. We've gotten really, really good at preventing Rh disease, which is fantastic. But that means other so-called minor blood group incompatibilities are now becoming more clinically visible. So the question for the future is, what's the next big challenge on the horizon?